To be on the panel sit in the delegates, and I would request Dr. Sonia Mohan, who is the State Consultant NHM Blood Cell, Andhra Pradesh, and having more than a decade experience, speaker of national regional conferences, and special interest in the hemophilia as well as in the hemoglobinopathies. To say a few words of the meeting objective and set the context for the further meeting. Over to you, ma'am.
A very warm welcome to all the speakers, delegates and the dignitaries who were on the dais. I am Dr. Sonia. I represent Andhra Pradesh Blood Cell. So I am here to discuss the meeting objectives of today's CME and the blood disorders in AP. So the meeting objectives basically revolves around the blood disorders, especially hemophilia, sickle cell and thalassemia, as you see. So coming to the current data, as per the disease burden in the state, we have sickle cell anemia with patients registered as 1,687, thalassemics are 2,155, hemophilics, that is 2,113, in which hemophilia A is more, that is 1,471 cases with factor 8 deficiency, and hemophilia B, that is factor 9 deficiency, 259 patients have registered, and other disorders like Lanzmann's thrombocythemia and other blood disorders accumulate to 283 patients. So coming to hemophilia, we all have the basic knowledge of or we come up with the scenario of seeing patients with joint pains and all. But there is a lot more involved in hemophilia other than the joint pains and things that we see. So basically, which is a bleeding disorder. Heme means blood and philia means affection. And so hemophilia A, as discussed, is a factor 8 deficiency, which is the X-linked inheritance. Hemophilia B again is a X-linked inheritance, recessive pattern. Hemophilia C is an autosomal recessive pattern with factor 11 deficiency. And for diagnosis, we usually do a bleeding time, clotting time, prothrombin time, APTT or a thrombin time, and other tests required. This is usually done in the current scenario in our government setup. Regarding factor assay, so if there is a particular deficiency of a coagulation factor, we tend to do a factor assay, specific factor assay or a mixing study, which is usually not done in our current scenario in the government setups. Usually patient is referred to a higher center. And factor inhibitor factor inhibitor assay is also not being done in most of our centers, and so patient has to approach a higher center. The treatment modalities available for hemophilia patients, as Dr. Prasad sir has discussed, there is a constant evolving of the treatment options for these patients. So currently we have coagulation factor therapy, which includes standard half-life factors and extended half-life factors, which can be given on demand. Mostly it is given on demand. We still don't have a prophylactic therapy pattern in our state. These factors are mostly plasma-derived or either recombinant. So coming to the non-factor therapy, we have a pilot project that is launched, which is a prophylactic therapy with a monoclonal antibody that is about to take on board. Coming to bypass agents, when the patients with hemophilia on repeated factor injections develop inhibitors, these patients are given bypass agents, which is factor 7, and some centers also give APCC, that is activated prothrombin complex concentrate. And currently in our government setups, we have factor therapy, non-factor therapy with pilot project, and bypass agents that are available in our government teaching hospitals and medical colleges. And we are trying to extend it to the district level hospitals also from this financial year onwards. So hemophilia patient basically needs a lifestyle management, proper care when they have a bleed, they need to be administered the factor injection within 2 to 6 hours of bleed, and proper nursing care, dental care, physiotherapy, all these things are underrated when it comes to a hemophilia patient. So regarding hemophilia, the new treatment modalities and the early prophylactic therapy, if it is initiated, will aim at achieving goals like disability-free life in a hemophilic patient, and also the patient having a state of hemophilia-free mind, which is the ultimate thing we actually want. Over to sickle cell anemia. We have sickle cell anemia, which is an autosomal recessive pattern of inheritance, and the National Health Program is going on regarding the same since July 2023. That is Sickle Cell Anemia Elimination Mission, which aims at eliminating sickle cell anemia by 2047. So the diagnosis is mostly done by CBC count, sickling test, peripheral smear examination, rapid card test, which is done in the Sickle Cell National Program, which is the point of care test, POC kit. And the final test to diagnose a sickle cell anemia and its variants is HPLC method, that is high performance liquid chromatography. Earlier we used to do HP electrophoresis, that has been replaced by HPLC. So when clinicians write HB electrophoresis, usually what is done at most of the higher centers or at labs is HPLC. The treatment modalities available for sickle cell anemia include sickle cell crisis emergency management, oral hydroxyurea therapy, and currently we are using leukodepletion filters also, which is bedside, and later we are trying to involve lab side filter, which is used at the blood bank or a blood center. So blood and blood components are given free of cost for most sickle cell and thalassemia patients and other blood disorders as per the guidelines of the DGHS. And ion chelation therapy is also essential in these patients because they have multiple or repeated blood transfusions. So they need this ion chelation therapy after checking their serum ferritin levels. Adequate hydration, balanced diet is also required to reduce the oxidative stress in the sickle cell anemia patients. Obviously, long-term follow-up is required, but most patients are not compliant enough, but we should counsel them enough to be on follow-up. Coming to thalassemia, we have different variants, thalassemia major, minor and other variants, which is again autosomal recessive pattern, and diagnosis is mostly done with CBC count, peripheral smear examination, and again HPLC. Treatment modalities available: blood component transfusion with currently bedside leukodepletion filters, and there is ion chelation therapy. Again, adequate hydration and diet and long-term follow-up is required in these patients also. So, as per the current scenario in AP, what happens is after receiving an authorization certificate as a particular disease, a patient in government or in a private setup, after being diagnosed, either directly goes for treatment in the same center, requiring a PRBC transfusion or any component transfusion. That is usually seen in sickle cell and thalassemia patient. And when it comes to hemophilic patients, they usually get admitted at the government general hospitals or the teaching hospitals for factor injections when they have a bleed, spontaneous or for on-demand therapy of factor 8 or factor 9 or the respective factor that is required. Also, patients with inhibitors, they approach the government general hospital for factor 7 or APCC that was already discussed. Sometimes patients with blood disorders also register with the NGOs or the respective disease-oriented societies. That is when the Hemophilia Societies have pitched in, even decades before we introduced factors or therapies in our government setups. So factor therapy is given to such patients in coordination with the healthcare facility that is available or associated with those societies. And sometimes patients, that is thalassemics and sickle cell anemia patients, register with charitable or private blood banks. So So patients register with charitable or private blood centers just to obtain blood or blood component from them, and they go and get transfused at the center where they are admitted. Also, sometimes patients register with the blood centers which have daycare facility to transfuse blood. So they get admitted at these blood centers, they get transfused with leukodepletion filters filtering the blood, and then they go on the same day. Considering all this, there is a necessity of a state registry that needs to be maintained for assuring the patient more comprehensive care from a government setup. So, throughout the state, or a long-term issue that is there is unawareness. The unawareness can be at different levels. It can be with the policymakers like us, or the service provider, or the clinician, surgeon, or a dentist, or a nursing or a physiotherapist, or the patient himself and the public. So education is the key. So awareness at various levels and being updated in the recent advances in all these blood disorders is the main objective behind this CME. So the first objective is to create awareness, as discussed, among the patients, public in general, clinicians, surgeons, dentists, physiotherapists, nursing staff especially, and also clinical psychologists and the nutritionists. Updating them with the recent advances by conducting more CMEs, seminars, conferences, webinars, and also through educational materials and various IEC platforms. So the training of trainers session, DOT session that is being conducted today aims at all the clinicians being nominated from DME and the DSH and the pathologists from the ICHH centers to be attentive for the sessions today, because they would be considered here on as future trainers for the respective centers or their departments. The educational materials, posters and topic related PPTs will be provided to these trainers to spread awareness in their respective departments or healthcare facility. Hence, all the trainers will have to conduct a short awareness session as soon as possible when they go back regarding these blood disorders, hemophilia, sickle cell and thalassemia, to pass on their knowledge and the gist of the CME to your colleagues, junior staff and the nursing staff to enhance knowledge in your respective departments. The trainers will also have to share photos or video clippings of the awareness sessions conducted at your center, and an email regarding the same will be sent by AP SACS or AP Blood Cell to your department HODs or superintendent as soon as possible. So knowledge is the only treasure that increases on sharing. This is a line set by my mentor. So please go and share your knowledge. Objective 2 is to improve and strengthen diagnostic facilities, which is a major challenge in any state or mostly in Andhra Pradesh. So we need to strengthen our 5 ICHH centers which are located at KGH Visakhapatnam, GGH Paderu, GGH Kakinada, GGH Guntur and Kurnool. Coming to ICHH centers, there is a request that is actually placed to the DME to enhance these 5 ICHH centers into comprehensive treatment care centers for blood disorders, especially hemophilia, sickle and thalassemia, aiming at putting up a daycare facility where the patient can come, take a transfusion or a factor injection and go back on the same day. So a clinician on duty and proper nursing, physiotherapy, care and psychosocial support would be required for these patients. So this daycare facility, which aims at comprehensive care, is to improve the quality of life in these patients, because mostly these patients, hemophilics, are disabled in various capacities because of their joint disease. And hemophilics with joint active bleeds need therapy, that is factor injection, within 2 to 6 hours of development of a bleed. And these patients travel long distances just to take these factor injections, compromising their day at school or work, for being admitted for days for only taking these factor injections to control their bleed. Also, this adds a financial burden to the caregiver of the patient, who sometimes is only the sole breadwinner of the family. So, financial burden is also a major concern regarding the socioeconomic status of the patient. Also, the patient and their family dealing with a genetic disease, which is a burden again, brings in the family dynamics of the patient and the thinking. So, psychosocial support needs to be offered to such patients to avoid the psychological trauma which can't be explained in words. As we all know, these hemophilics have life-threatening emergencies, that is CNS bleed, GI bleed, spinal bleed, genitourinary bleed. So they need to be addressed at the earliest. And also nursing care, physiotherapy, dental care and psychosocial support and diet is very underrated in hemophilia and also other blood disorders for patients with other blood disorders. So objective 4 aims at encouraging 100% component therapy for all the patients. DGHS and NACO also encourages, as per the guidelines, to go for 100% blood component therapy rather than whole blood transfusions. As clinicians or surgeons, you all need to encourage the patient and the patient attendants especially to go for voluntary blood donations or bring in donors early enough so that they have blood that is reserved for the patient, anticipating the emergency or the requirement of blood in future. Why should I donate blood? That would be the question that most of the patient attendants ask. There is only one answer. There is no substitute for blood unless somebody donates blood. So blood can't be manufactured. Every 2 seconds, somebody needs blood. So take a break. All of us just remind yourself that being a doctor also, you can also donate blood at various occasions for a patient or on some scenario that is possible. So 95 to 96% of us rely on the 4 to 5% of the generous voluntary blood donors who donate blood on a goodwill. So we need to remember this. Objective 5 is to provide leukodepleted PRBC or blood components to the patients requiring repeated blood transfusions. We currently have bedside leukodepletion filters. We are also pitching in with lab side leukodepletion filters, which is filtering the blood, that is leukodepletion, which is filtering the WBCs in the blood center itself and then issuing the blood to the patient. So why do we need to leukodeplete blood? This is most required so that patient doesn't develop allo antibodies or allo immunization, to prevent allo immunization. That is, cytomegalovirus infection can also be prevented with leukodepletion. Leuko, which is nothing but white blood cells. So patients on multiple repeated blood transfusion not being administered leukodepleted blood tend to develop allo antibodies which actually interfere with the cross matching, and in future incompatible blood units are usually seen, and the patient, when lands up in an emergency, you don't find compatible blood. So avoid this scenario, especially when a patient is sickle cell or thalassemia. You need to consider to give leukodepleted blood. Objective 6 is a request actually. There is a e-Raktkosh app that is available, which is a national web portal, which is an open public portal. We request all the clinicians here to download the app, which is also available as a mobile app, which enables you to check the availability of blood in your district, in your place, or in a nearby blood center or a blood bank available in your place, rather than asking the patient whether the blood is available or not, or the patient attendant, because they will be in such stress that finding blood of a certain blood group would be difficult for them. At times, when you look into this app and help them, telling that a rare blood group is available at this blood center, that would be a relief to the patient. So, kindly download this app. This has multiple uses, like searching a nearby blood center, contact details of the blood center are available, which makes you easy. You can navigate through Google Maps and search your blood centers in your area. So blood group wise blood component stock availability is displayed in this app, which can be looked in by you to see a particular blood group or a blood component that is required. So a request for the blood component can also be placed on this app, and you can even schedule a voluntary blood donation on this app. So this portal is monitored statewide and in a nationwide way. Starting from April to June, we have various days for National Awareness Days on World Hemophilia Day being celebrated on April 17th, World Thalassemia Day on 8th May, and World Sickle Cell Anemia Awareness Day on June 19th. Thank you. Please donate blood, save lives.